me. And to continue the story, I will not linger because this is quite a very involved case. I noticed the reaction like, is it too good to be true? It's too good to be true to have this kind of case, but sad to say, occasionally we do see this, So you wish that all patients would present this way, The classic symptoms and no other problems, echo is positive, and we're all happy. We start the medications early, and we have a less complicated course of patients. However, we find more and more, because probably with strong index of suspicion, we find also that a lot of them come in and we're already suspecting Kawasaki at less than 5 days of age, of illness. So what happens is we're already entertaining incomplete Kawasaki. So thankfully, we have echocardiography to help us, guide us. But when echo is not positive, we still go by clinical features. So the heart of the matter is the matter of the heart, because as Christine and I were talking, as soon as the fever goes down, it's in the ballpark of the pediatric cardiologist. So it's quite a long follow-up if they have aneurysms. So my objective to discuss the indications for 2D echo, and if allergic to aspirin, I think Christine already mentioned something about that, and to discuss the duration of treatment regarding this case, which will probably touch some of what we have already been seeing in our practice, okay? In this journal, given by Duarte, gave a very good summary of the myocardial problems we encounter. So not just coronary artery lesions, but a lot of them presents with myocarditis. So even if the patient doesn't present with positive echo, sometimes we are so focused on the echo, we look at the results and not realizing there are other telltale signs. I've had referrals wherein it's incomplete, and the only thing I see on echo is a pericardial effusion, and I'm thankful for that, because I can make a clinical impression. I said, most likely, if there's no other explanation, it's Kawasaki disease. So myocarditis in 50 to 70%, pericarditis with pericardial effusion in 25%, and notice in untreated cases, coronary artery aneurysms in 15 to 25%. I think in the Japanese, about a long time ago, 18 to 30% would have aneurysms back when they did not use IVIG, which has gone down to about 4%, 2 to 4% now, even with IVIG use. So that's a very quite big improvement with your IVIG. So you also have systemic arterial aneurysms. Joanne and I were discussing earlier that a patient presented with axillary aneurysm, and you can find it very rarely in less than 2% of cases. So valvular diseases may occur. They will have MR, not only in the acute phase, but even after that, if you have focal points of ischemia, mild aortic root dilatation, and myocardial infarction, thankfully in less than 1%. And I always pray that I will have a patient coming in early, able to afford the IVIG. That way, I would not have a problem of thrombosis to worry about in the future. So the manifestations of the cardiac involvement depends on whether you're in the acute, subacute, or chronic phase. So in the acute and subacute, you see pancarditis, reminiscent of your rheumatic fever, isn't it? You'll have mitral, tricuspid aortic regurgitation, some sort of myocardial dysfunction. It's not unusual to see their ejection fractions going down, and then to recover later on. Then, of course, I mentioned earlier pericardial effusion. Coronary artery abnormalities will be seen in the subacute phase, 7 to 14 days, as early as at times 10 days, or at the end of the 7th day. So perivascular inflammation and ectasia only means that the coronary artery is uniformly dilated. And our coronary arteries, if you look at the echo, would have a normal tapering, wide proximally, and it tapers towards the distal side. So ectasia will be also suggestive of myocardial involvement because there's failure of the tapering. So you look for those in your echo result. And of course, your aneurysm. The chronic phase is what we're scared of. That's why we want to treat and diagnose these cases early. So you can have coronary artery insufficiency, and it's reminiscent of patients having myocardial ischemia or infarction in the adult stage. They can be regional and global dysfunction, which only means that portions of your heart are weak. And then ischemia-related atrioventricular valve dysfunction, stenosis, thickening, and alarmingly, thrombus formation. I have only seen one case that years ago in my fellowship training, and it's a patient of Dr. Ortiz, I remember, that's had thrombus and had to put on anticoagulation. So I searched the literature in case we have local studies on Kawasaki, and this is what I found. There might be, the doctors may be here right now. Raise your hand. So anyway, it's a 10-year review of Kawasaki disease in 1999, and they said that in 1987 was the first documented coronary aneurysm in a 5-year-old boy. In this case, they had 20 patients, 5 of which, or 20%, presented with cardiac problems. I don't know what they were, but one of which was aneurysm. So I thought that was interesting note right there. So why do we do 2D echo? Of course, to establish a baseline. No matter at what day of fever, get a 2D echo. And then especially if you get them early, less than 5 days or less than 10 days, and not all the symptoms have manifested like we were discussing earlier, what we do is we keep monitoring. You have to keep following up and see if there will be change in the coronary artery. And if there's other signs other than coronary artery changes like your effusion, valvular abnormalities, then you can go ahead. If the clinical features are there, even if it's incomplete, you can go ahead and start your treatment. So this is helpful, especially when it's incomplete. It helps us in guiding appropriate therapy and surveillance of coronary artery changes. Okay? So earlier, Christine mentioned this, but I would like to say that a negative coronary aneurysm in the result does not preclude the use of IVIG. Again, go by clinical features. So diagnostic imaging modality of choice is your transthoracic echo. Nowadays, we are thankful to have CT angiography, and which will help us delineate the coronary arteries better without the invasive procedure of a coronary angiogram. Okay, long-term consequences of these abnormalities may manifest in adults as myocardial ischemia, and they say as late as 18 to 20 years later. So now, more vigilant screening, including your metabolic syndrome and also your lipid profile, are being followed. Do you practice? Because I remember, sometimes we forget to advise them, especially those who've had coronary artery aneurysm, remind them about lifestyle changes, their diet, and monitoring of cholesterol in these kids. So what happens to the coronary arteries? Can have dilatation aneurysms or giant aneurysms. As soon as 7 days, I mentioned earlier, and with the peak internal luminary diameter reaching in about 4 to 6 weeks. So that if there's a regression of coronary arteries, usually by the 8 to 10 week, we say, wala na siyang recurrence or a coronary aneurysm, okay? Now, I already mentioned that CT coronary angiography has emerged as an exciting new tool. So this is our patient. Let's go back to our patient. 6-month-old male. By the time the echo was done on the second hospital day, thankfully, it had a dilated left main coronary artery. So this is just to show you on the left side, a normal coronary artery would be tapering. This one is ectatic, no? It's dilated. And on the other side, And on the other side, you have pericardial effusion, where the arrow is, that dark portion behind the posterior wall of the left ventricle is a pericardial effusion. So what are coronary artery abnormalities? You have normal, saccular, fusiform, could be segmental, or just ectatic dilatation. So the patient age, as mentioned earlier, played a role in the development of aneurysm. And a study in Japan by Naomi Kitano, and this is 2014, both patients, it was U-shape, okay? Patients less than 11 months old and those over 48 months old found to be significantly had a higher risk of developing aneurysms or coronary artery lesions. So take note. Okay, and then also other risk factors were already mentioned earlier: male sex, delayed diagnosis and treatment, because of course the giving of your IVIG is delayed. So others will be thrombocytopenia, lower hemoglobin or hematocrit, and lower serum albumin, and we remember this as your Haradas score. Okay. So just I borrowed this from my friend Juliet, and this is occurrence of arteritis and Kawasaki disease. Coronary, you will see in 96%, and others, renal, paratesticular, mesenteric, pancreatic, hepatic, iliac, so all down the line. So when we see patients perhaps presenting with ischemia in these areas, and they have a history of Kawasaki, maybe they need to be referred for angiography. Okay. So we follow the American Heart Association of whether our normals. So more than 3 millimeters, small to medium. Large is more, medium to large is about 5 to 8, and more than 8 is your giant aneurysms. Okay? So what is the importance? Aneurysms typically develop in the proximal segment. So in this case, our patient had ectasia, thankfully. They may have thrombosis, myointimal fibrosis, and stenosis. So in echo reports, we usually say no turbulence along the coronary arteries, and we specify in the proximal because the distal part of the coronaries is very hard to visualize by echo. And thankfully, the ones involved are your proximal segments most of the time. So of course, you can have ischemia infarction, and myocardium can be affected without coronary disease. So I mentioned earlier, we're following more of the Japanese, which is if you have an artery, 1.5 times the size of the preceding, and then less than 5 years of age, more than 3 millimeter, more than 5, 4. And then the American heart is down at the bottom, small, less than 5 millimeter, medium 5 to 8, and giant, more than 8. Okay. So, again, we need to do echo, determine if there's valvular regurgitation and dysfunction, and this influences our follow-up. So one of our objectives is how long do you follow up, how frequently you do the echo, and how long is your treatment. All will be answered by how is your echo. Okay? So if there's any suggestion of coronary artery abnormalities, and depending on the result, then you can do it more often, lesser, discontinue treatment, or not. So I'll mention that earlier. So initial presentation, the fate, this is what happens, regression in 30 to 50%, and localized stenosis can be seen about 4 to 12% as older as 21 years. And then occlusion, thankfully less than 1%, and segmental stenosis. So over here in the middle, you will see occlusion, and then there are already formation of collateral or nutritive vessels. And on the very right, again, another area, there was occlusion, and thankfully recanalization can occur in about 70% if you give your IVIG. Okay? So 50% resolution. Those with giant aneurysms, just for a show of hands, how many of here in the audience have had giant aneurysms reported in their results of coronary arteries? Can you raise your hand? 2, 3, 4, about 5 in the entire audience. So that's how rare it is, but it happens. So they are to be carefully followed up because they can have a higher risk of rupture, thrombosis, and stenosis, which may cause, again, sudden death. And these usually do not regress. So they keep following up, and later on are candidates for coronary artery bypass graft. So how do we follow up and wait for all the slides? Oh, I'm sorry for the appearance. So 2 weeks, appearance of cardiac abnormalities. So we do baseline, we do 2 weeks. I don't do 2 weeks if I've given IVIG and they're careful with their aspirin. 6 to 8 weeks after diagnosis to check if there's still remaining aneurysm. And then in complex cases, it's done more often, like every 1 to 3 months, 6 months. So for our patient, we have a medium-sized aneurysm, 5 millimeter. I would do an echo every 3 months, check if there's any thrombus formation, continue my anticoagulant, aspirin will be enough. If there's a viral infection, we hold it and we give dipyridamole. And if there is an allergy, again, that's all we can give is your dipyridamole aside from your aspirin. And then for giant aneurysm, we have to give them warfarin and aspirin combination. So for giant aneurysms, every 3 months, echo, ECG, and sometimes they have to undergo stress tests. And so that they will not tire, we do dobutamine stress test. So you will give Dobu. So this was our patient. So I already mentioned what we'll be doing for the patient. So baseline, 2 and 6 weeks of illness. If they are normal at 2 weeks, seldom develop new abnormalities. Those who have higher risk, frequent echocardiograms, and first 1 to 2 months following diagnosis, we check for arrhythmias, heart failure, valvular insufficiency, or myocarditis. So for complex, at least twice a week in the initial portion, once weekly, first 45 days, and monthly until the 3rd month of illness. And then every 3 months, as I mentioned earlier. So I think you're going to have a copy of this. I gave my consent for everyone to get a copy. So accurate assessment of coronary artery morphology is very important. Okay? Biglang natahimik sila. Okay. And long-term follow-up is very important because some of them have shown even 20 years later some lesions, and this is where your CT angiography comes in. The gold standard for diagnosis is your coronary angiography, but with good centers who does CT angiography, this is very good, and they can already delineate the coronary arteries. So this is beautiful, lent by Dr. Bernard Laya in St. Luke's. So this is on loan. Okay, and then other side, beautifully depicted the coronary artery lesions. So, I think we've answered all these questions. Duration of treatment, I have answered. And other treatments, supports, if they come in with heart failure, I have not had to resort I have not encountered any patients with shock, thankfully, but I've heard, rarely they can occur with shock, like toxic shock symptoms, and then they are put on supports, and as I mentioned earlier, statins. So this is just to show and answer the question earlier. If you have an allergy to aspirin, what we have here is your dipyridamole. And then clopidogrel at 0.01 milligram per kilo, they can start, but I have no experience with it. My foreign counterparts, my friends, they have used it, but most of the time aspirin is useful. And when they're confined for other reasons, they cannot take these antithrombotics they have to undergo sub-Q heparin injections. So I've already mentioned this. Non-responders, as mentioned, have an increased risk of coronary artery aneurysms, especially giant aneurysms. So, and then they are usually put on warfarin and aspirin combination. So, other testings, electrocardiogram, stress testing, coronary angiogram. And don't forget, after 1 year from the time of start monitoring your lipids, and if in 8 to 10 weeks there's still ongoing inflammation, some have already recommended taking baseline parameters. And the drug of choice that they've given are atorvastatin and pravastatin because it also takes care of the myofibroblast proliferation. So, in a study by Duarte, they demonstrated that those with a history of Kawasaki disease have a long-term structural and functional alterations that increase the propensity towards subclinical atherosclerosis with age. So with that, I will recommend a more than 2-year-old screening for dyslipidemia, fasting lipid profile, 1 year after the acute phase, if results are normal, every 5 years. So let's include this, and of course, tell our patients to don't forget lifestyle, take care of the lifestyle of their patients, and Philippine Heart Association adopted the American Heart 5210 and added a 0. So 5210, 5 servings of grain and vegetables, limit computer time to 2 hours, 1 hour physical activity, 0 to sweets, and 0 to smoking. I have to plug that for wellness sake. But anyway, you will get a copy of this, and thank you so much. So for this patient, you know how to follow up, and I hope that will be a guide to us. So thank you so much.